Welcome back to those who've been with us all morning, and hello and welcome to new people to this stream. Just to remind you, this is about how your practice can be adapted to survive. So it is my great pleasure to welcome two innovative GPs again. The first is Naresh Rati, who is a GP, executive partner of Vitality Partnership from Birmingham. And also to introduce to you Tim Reed, who's a GP from Suffolk and chair of the Suffolk Federation. And both Naresh and Tim are going to describe some organisational models for general practice and how you can then use those models to pitch for services using the AQP route or enhanced services route. So without further ado, over to Naresh to kick us off. Thank you very much.
Thanks, Nav. We've agreed that we're going to try and cut our talks a little bit shorter, so there's a greater time for Q&A. So I'm going to skip over a couple of slides, and I just apologise for that in advance. So we are in an environment, as you all know, where procurement and bidding is going to be part and parcel of the environment, as it were. And it's important to recognise, I think there was a Q&A question at the end of the last session around conflicts of interest, that as CCG members, GPs, we also have to obviously potentially declare and in a transparent way our interests if we do become providers and start to bid for some of these services that CCGs are potentially going to put out to tender, as it were. Broadly speaking, there are a couple of sort of tender routes, that sort of the big shebang where the CCGs may want to tender for a whole care pathway, where they put it out to advert, and then you have expressions of interest. Then there's a PQQ, the qualifying process, in which case can you demonstrate you as an organisation, as a provider, are able and are capable of delivering that service, and then how you're going to deliver it, an ITT, and then you get awarded it and start the service. Or an AQP model where there's a service spec that's delivered, put out, and if you can deliver that service spec and demonstrate the quality and other markers that the CCGs want, then potentially you'll get awarded that contract with no guarantee of any volumes. So that does provide opportunities for potentially practices to come together and look at how they may want to become providers of such services in the future, in a network form or in a larger organisation such as ours in Vitality. Why are we doing this? Well, we're being asked every year to do more and more for the same or less amount of money. And if you are going to embark on perhaps joining together, collaborating with neighbouring practices, I think it's important that you articulate that to your staff and to your partners in terms of what that vision is. One of the lessons that we learnt when we went down our journey around forming the super partnership was to ensure that our staff really are engaged right from the outset, because change means uncertainty and nervousness in an environment which can potentially cause sort of instability around job uncertainty. Understand what's happening with your GPs locally. Is there an appetite for coming together and doing something or not? Who are the sort of potentially the innovators in your patch, and perhaps approaching them about collaboration. Understanding what your commissioners and NHS England will have a view in terms of procurement will also perhaps influence the model in which you want to try and come to formulate. Data, lots of data. From a commissioning point of view, it's important, but equally important from a provider point of view, understanding the demographics of your patients, the patients that potentially you're going to serve, and the sort of services that you are going to bid for. We have invested in our own IT support, which is separate from what we get from commissioners, just to sort of help us support in terms of some of our bidding processes potentially in the future, but also understand our internal processes from an IT point of view. And then if you are thinking about coming together, what's the right size? How big? Is it going to be based on geography or something different? And Do you form a partnership? Do you form an LLP? Do you form a community interest company? What's the right model and what's the right vehicle for delivery? And I would sort of say that actually what you should be doing is looking at what is it we want to do? Do we want to come together to try and support each other to perhaps deliver some enhanced services collectively? Or do we want to actually go into this bidding game and look for AQP services? What is it that you want to do? And then perhaps actually that will then determine the sort of vehicle and the model that you want to formulate. So over the past few decades, general practice really hasn't changed. Mainly sort of multi-partner practices, 10, 15,000 patients, and particularly in the inner cities, smaller single-handed GPs. Tim's going to talk to you about the federated model and what they're doing in Suffolk. And what we did in Birmingham was actually go the whole hog and put everything into the pot, our core GMS, PMS, enhanced services, specialist services, all into the same pot and formed a single partnership. This is where we are based. This is our CCGs. It's actually slightly out of date. There's two of the CCGs have merged, but basically we're in Samwell, West Birmingham CCG, which is just the north end of Birmingham and into Samwell. And the green represents our cluster of practices. There's two blue dots which represent the current local acute trust, and then there's a third blue dot number 3, which is the new proposed acute trust. And it's a deliberate strategy on our part from the partnership to really try and focus in a single geographical area to try and take advantage of what's happening locally. So what are we? What is Vitality? It's a single partnership, local, based in a single geographical area. We have over 55,000 patients currently, and it is sitting behind that a very commercially focused, commercially based structure, which I'll talk about. I think there is a theme and a thread throughout the conference over the last day or so around integration and how locally we can come together to try and integrate. And this is one of our models in terms of horizontal integration and bringing together primary care and community services under a single organisation. We have EMIS Web, a single IT system, and that allows, across all our practices, and that allows obviously a lot more fluidity in terms of patients moving across from practice to sort of receive their care depending on where the particular speciality that they need sits. When you're talking about bidding and tendering and what have you, don't just consider necessarily what the commissioners, your CCGs, are going to put out. Having a large-scale organisation gives you an opportunity to look outside of that traditional model. So the universities, for example, we have a large university contract. We have very strong links with Birmingham University, and there's huge opportunities for us to attract trainees, medical, nursing within such a large organisation. We also have a primary care research nurse within the practice, which again is a huge opportunity for primary care research, which really isn't delivered or being delivered to the sort of standards that potentially this model offers. A little bit of history. So the two founding practices came together in 2009, and that really formed the foundation of the partnership. And over the subsequent 4 years, we've sort of grown by mergers and acquisitions to our current size of just over 50,000 patients. And that's within the context of our CCG of just over 500,000. So we represent about 10% of that. And we are all within a single LCG local group of about 125,000. So we are quite a strong voice within our CCG. We have a number of contracts, PMS and GMS, some number of specialist services, private contracts delivered across all our sites. These are some of the community services that we are able to deliver. And the reason for putting the slide up is not necessarily to sort of say these are the sort of services that you can do, but actually we employ 2 full-time rheumatology nurses, we employ 2 full-time dermatology nurses. These are, 40, 50, 60,000 pound salaries, huge investments potentially in terms of risk on contracts that the CCGs are going to put out to tender. If you're a small practice, can you really take that sort of level of risk on? This goes back to what I sort of said was actually try and understand what you want to do and then let the structures follow rather than having a deemed structure in place. So we started with a partnership, and then over the years we've obviously inherited a community interest company. We've got a limited company which delivers some of our private services, and obviously a property company as well. So the ability to scale allows you to make longer term investment decisions. You have the core of your GMS and PMS contracts on which to hinge some of the investment decisions for contracts which are going to come out for tender, which may be 1 year, which may be 3-year contracts. So how are you going to sort of potentially manage that risk? Clearly, there are opportunities to diversify income streams and possibly potentially increase income streams within the context of actually these are big investment decisions that you're making and the costs that are associated with that. Scale also gives you an opportunity to make commercial decisions rather than decisions necessary. This is a business decision as well as obviously what's right for the organisation and perhaps the patients. It allows you to invest in your property, bigger investment decisions, an ENT contract that's going to come up. That's tens of thousands of pounds of equipment that potentially you're going to have to purchase. How are you going to do that if you're a small practice? And also gives you opportunities to think outside, like I said, private contracts outside of the NHS and outside of the commissioning groups.
Thank you very much, Naresh, and we'll just follow straight on and perhaps have questions at the end, if that's okay. Over to you, David. Sorry.
Yeah, thank you. Well, I want to just talk a little bit about forming a federation of independent practices. I mean, we're all too familiar with the challenges that primary care is facing at the moment of rising workload, increasing complexity of workload, demographic changes, financial constraints, difficulty recruiting, the list goes on really. And in association with that, we're now seeing competitor organisations, corporates, perhaps possibly foundation trusts, other organisations moving in, competing for parts or even the whole of our contracts. So the question is, how as GPs are we going to respond to these challenges that we face? And Naresh has set out one possible example of what's happening in Birmingham, and I'm going to talk a little bit about a slightly different arrangement, what's happening with the GP Federation in Suffolk. But perhaps before we talk about federation, perhaps we just ought to say, well, what is this Suffolk thing? Because it's not in London, but as you can see, it is attached to the mainland, and we do speak English there. It's the Federation has got 40 practices, all 40 practices in East Suffolk belong to it. They cover about 360,000 patients in total, and 2/3 of those are a rural or small market town, and 1/3 of them are in the county town of Ipswich, which is significantly more disadvantaged than the rural area and more disadvantaged than comparable county towns elsewhere in the south of England. General practice is very stable in our area. It consists entirely of the traditional partnership model, independent contractor model. The average partnership size is 9,000 patients, and it's very rare for a practice to be put up for tender by the CCG or to be taken over by another practice. So you've got a situation where GPs are thinking, hey, look, there are new challenges that we're facing and there are new competitors, but they very much value their own independence, and they're proud of the practices they work in, and they want to preserve their own independence and autonomy. Previously in our area there were 4 commissioning groups which stem from the old arrangements when GPs could both commission and provide. Under the previous administration these groups arose. But with all the changes, they had a review of whether those groups were still fit for purpose, and they decided that the way in our area to respond to the threats that opposed to us was to form a federation of independent GP practices. That the traditional cottage industry model wasn't going to be able to compete and put in bids for the public health leases, which are going to be done county-wide. It wouldn't be able to compete for other contracts, the sort of thing that Naresh was mentioning, on an individual practice basis. So after a significant period of discussion, negotiation, those 4 commissioning groups came together to form a federation. The sort of skills that the federation can add to individual practices is that it allows them to work together to address issues which they would have difficulty addressing individually. Things like sharing best practice, things like forming a recruitment and retention policy for the whole area. Clearly impossible for one practice to do on its own, but something that a federation could do together. Buying defence cover is another obvious sort of facility that a federation would offer. And of course a federation brings other skills that, again, an individual practice might not have access to. Senior management, contacts at CEO level with other local players such as the hospital and the CCG. So our federation has just 2 objectives. That's clearly why I've put 3 up on the board here. But it exists to be a provider group, to provide high quality patient services in the community. Hopefully those contracts for providing services will generate a surplus, and that surplus is used to offset the costs of running the federation, and of course to provide services in an innovative way, and our federation does do that. The other objective of the federation in Suffolk is to enhance and develop and preserve the independent contractor model. We believe that has many advantages, and indeed in the days of the co-op that was the model by which practices came together to provide out-of-hours services, which are far in excess in our area, far in excess in terms of quality compared to the service which is provided at the moment by a private sector organisation. The business model that we're employing is, as I've said, to win contracts and run services in an innovative way. That can then generate some surplus which we use to offset the very substantial costs of running the federation. It's costing us about $250,000 a year. We employ a senior manager, an operations manager, other support staff. There's a booking centre, we have offices, we have our own IT, we run 3 or 4 separate contracts, the board have to be paid, and so the costs of running the federation are very substantial. That pushes us towards trying to expand the federation beyond what it covers now, possibly to cover the whole of Suffolk, or even liaise with other organisations on our peripheries in other counties. Practices have been invited to contribute 30p per patient to the setup, But that's more really a statement of commitment than any real contribution towards funding. There's no intention to seek further funding from practices. The Federation will have to pay its own way through its contracts. Some people are sceptical as to whether a federation might succeed. They say, look, it's going to be very difficult making decisions with so many practices involved. They say that you need to have a nimble organisation, something that can react rapidly. But the Federation does have some very notable supporters. And these are two local supporters of the Federation in Suffolk. We've got Sir Bobby Robson on the left and Sir Ralph Ramsey on the right, who are both managers of Ipswich Town Football Club. And their federation was, of course, the International Federation of Football Associations. But there we go. Got some issues that you might want to take up in the Q&As, issues that have come up for us during the sort of start-up process. Federation is a not-for-profit community interest company. It started just on the 1st of April, so it's in its early stages. And some of the issues are, can this federation model really adapt or allow practices to respond to the types of challenges that we outlined at the beginning? Can it really compete with other providers such as Harmony, Care UK, Virgin, etc.? What about the very significant start-up costs? How would a federation get going? In our instance, we were lucky enough to inherit managers and some cash and contracts and officers from the old commissioning groups. But if that wasn't around in an area, how would it be financed? There's the conflict between the need for scale in financing, and yet GPs want to have their own local organisation to feel they belong to something that's meaningful on a local scale. And in that sense, we've kept the original commissioning groups to act as locality groups. And finally, you've got this seemingly increasing disparity between how management and politicians see healthcare delivery in terms of variation, access, costs, targets, population health. How does that reconcile with us as GPs and our perspective on health, which is very much individual, based on the consultation, patient-led, and a focus on continuity? Can the Federation provide a link for those two disparate ideas? Thank you.
Okay, so we've got around 5 minutes or so for questions and answers. So can I just get a sense of who wants to ask some questions out there? Is there anybody out there? Got one there? Any others? Okay, shall we just hear what your... we'll take both questions and then we'll get our colleagues to respond. Do you want to just introduce yourself? Make it very brief, if that's okay.
I'm a GP from Mansfield, Dr. Prabhu. Hi. And question for Tim Reid. This model is just for providing services rather than commissioning services. And then what kind of model do you use? Is it limited company or is it, how do you go about getting practices?
So just want to hear about the structure there. And what was the question? Just hang on a minute. Just microphone coming.
How does the Federation deal with urgent and emergency care, and do you link with the ambulance service and the 111 service?
Okay, so two for Tim there. Kind of what's the structure of the vehicle and how it links into other services?
Yeah, sure. The Federation operates as a not-for-profit making community interest company. Does that answer your question? There's no signed contract with the practices, but there is a shareholders agreement. It is deliberately vague. It asks really practices to be committed to the Federation and to operate in a spirit of collaboration and cooperation. But when it comes to individual contracts, each one is different, and that has to be managed after consultation with the practices as to how it's to work. Another principle of the Federation is that all practices, large or small, should have an equal opportunity to provide services.
And did you want to pick up a question about other services?
And the question about connecting with casualty and emergency services is, at the moment, our federation isn't involved in the provision of emergency services. So that's just running by CCG commissioned services as usual.
Okay, any other questions? So we've got two. So Simon, do you want to go just a quick question and then we'll pick up your question as well? We hear both and then we'll take those.
Thank you. Simon Gilbert, GP. A question for Dr. Rati. As your organisation expands, how do you deal with the issue that the kind of incentives for partners can be diluted, in that if you set up a new service, the kind of profits from that are spread across the whole organisation? How do you kind of stop people coasting?
Should you just take that one while the microphone goes around the other way?
Yeah, so the fundamental core of our business is partnership, and partnership is based on trust. And so, yes, there is a large trust element that we're all working in the same environment, in the same direction. We all believe what we're doing, and we're all working within the parameters that we work for the partnership. Having said all of that, clearly we need to have a sense check, and that's where the executive board members really do sort of hold the partners to account in terms of what they do on a day-to-day basis. So me, for example, I have one-to-ones with all my partners to sort of just understand what they do, what a working week is. Some of us are more clinically focused, some of us are more managerially focused, some are focused towards the CCG. And so as long as, broadly speaking, we're all doing things for vitality and not for ourselves, then the trust element is first and foremost.
Okay, and question from over there.
Andy Warrington, GP. Question for Dr. Rati. Your organisation pulled together GMS and PMS contracts. Was there an issue of seeking permission for the merger, and was there a threat to the contract status and PMS uplifts, etc., when you came together?
Yes, so we have had a very good working relationship with our PCT. And so in Birmingham there's a huge disparity in terms of quality, if I can put it that way, amongst some of our practices. And so in return for tackling and merging some of their more difficult problems, some of the smaller single-handed GPs, for example, they allowed us to sort of merge or take on their contracts at the full contract value. In return, we also had to accept some enhanced KPIs for some of our contracts. So there were COF plus performance indicators that we had to agree with the PCT then, in return for getting the full contract value.
Okay, we're just going to have to call it quits there now. So just a big thank you again to Naresh and Tim. You've heard the future general practice defined somewhere between those two, and thank you all very much for listening.